In the library tomorrow at 12:30. Our benchmark is going to be 68. If you're repeating the course, and that's for points, 68 for points. If you are repeating the course, then you still only make a 68. You don't have a different score from everybody, and you take the same test as everybody. Please be quiet. There was a complaint that y'all were disruptive in the library last time, so please make sure you're extremely quiet. And I don't know if it was students or faculty that complained, or the library workers, staff, library workers, but they said y'all were disruptive. So please be extremely quiet when y'all come in. What is it? Time. 12:30. 12:30 in the library. And 68 is for points. You still have to make a 60 as the benchmark overall, but 68 is for points. And most of the time we have several students that get it, so it is possible to get it. The hypothalamus is in the brain as well, so if there is increased intracranial pressure, a lot of times the patient will also have trouble controlling their what? Body temperature. They may have to be put on a cooling blanket or a warming blanket. And they may have an internal temperature probe, which typically can be assessed by what else? The Foley. The Foley will a lot of times have a temperature probe that can be an internal temperature probe that can be hooked up to the telemetry monitor with other vital signs on it. And you may have to adjust the cooling blanket or the warming blanket based off the patient's temperature. This is a monitor that's on a child. They can assess the, this is an external ICP monitor. What do I have to have in order to assess it externally? I either have to have a craniotomy or one of my ventricles can be patent. So it's not very often you can use an external one, but they can sometimes use them on infants. Because do we want to go in and stick a probe in a baby's head necessarily? But might we need to assess intracranial pressure? So sometimes they can do it via an external monitor through the ventricle. But if your patient has a craniotomy, it is possible. They bore a little hole in, and then they feed the monitor / catheter typically into the ventricle, and that's where they read the pressure from. So there will be a little tube that comes out onto a transducer, and that transducer is going to be in line with the hole in the baby's head or in the patient's head. If you raise the person above the transducer, the hole above the transducer, what would happen to my pressure? It would read lower than normal. What if I put the patient lower than the level of the transducer? It would read too high. So before you go adjusting anything, make sure that you have the level of your transducer properly aligned. They used to be by gravity feed, and I don't know that they're by gravity feed anymore, but if the level of the transducer was too high, and it's by gravity, what would that cause my cerebrospinal fluid to do? Gravity. Run out too quickly. And then what if I dropped the patient too low and it was by gravity? It would cause cerebrospinal fluid from the bag to go dripping back into the patient's head. So that's another reason to make sure it is level now. I don't think, I don't know for sure. It's been a long time since I took care of one, so I'm not sure if that's the same case now, but it's always a good idea to keep that in mind. So what would I need to do if my patient was going for, let's say they were going for an MRI? What would I need to do to the bag, do you think? Turn it off. Who do I got to make sure that I can turn it off before I turn it off? The physician is probably typically going to be the neurosurgeon is going to be the one that controls the orders for the transducer and the monitor. What if my pressure was too high and I thought I needed to turn it off? Am I probably going to get to turn it off? Am my increased intracranial pressure was too high? Okay. I'm probably not going to get to turn it off, right? So that's why you got to make sure you call the doctor, and you got to make sure that he knows how long you're going to be anticipating it being off for. Does all that make sense? Okay, so what has to be in line with the hole in the patient's head? The transducer. And what are my orders going to be based off of? To do with the controlling of the cerebral spinal fluid. How do I know if I'm going to turn it off or turn it up? The millimeters of mercury. And who's going to tell me how to do all that? The physician. He's going to have the physician's going to have orders, or the surgeon's going to have orders that will tell you how fast and how slow and what you need to do with the transducer. So what did we say seizures were? Abnormal electrical conduction. So what controls my muscle movement? The electrical conduction from my brain. So if I'm having abnormal conduction, what am I going to have with my body? Abnormal muscle movements. And how do we know if I'm having seizures or not having seizures? The EEG. There's lots of different types of seizures, and the location of the seizure is going to depend on what is going to cause me to do what? Have the different signs and symptoms. So if I have one in one place, I might have one type of activity. If one's in the other place, I might have a different kind of activity. How do I know who decides if it is epilepsy? The neurologist. And it's based off of how many seizures do I have to have? Without any known cause. It can't have a cause to it. If I have a fever and I have a seizure from it, does that mean I have epilepsy? No, because there's a cause, and if I only have one, then it doesn't equate to epilepsy. So if it's typically, what if trying to think of something that would be weird. What if I did some kind of crazy drug and had a seizure from it? Does it have a cause? So is it epilepsy? Because what's the treatment for that? Quit doing the stinking drug. What if I have a febrile seizure though? When I do have a fever, I'm at risk for having a fever again. But even if I have a fever with two different, if I have a seizure with two different fevers, that's still not epilepsy. So what do my parents need to do whenever I have a fever? Get my fever down quick and monitor me. We're going to look at the different types of seizures in just a minute. So if If the patient is aware of their abnormal movements, it's called simple. And it's simple partial. If they become unaware of their activity, then it's complex. And then tonic-clonic is usually the generalized seizure that we look at, but we're going to look at other generalized seizures in just a minute. There's a neonate. Do y'all ever see babies that kind of jerk? The myelization of their nerves is not complete. So the nerve has a coating to it called the myelin that helps insulate the nerve. And what would insulation do? Block interference and keep the electrical conduction moving down the nerve properly. So without that myelin being there, the conduction through the nerve is not complete. So if they don't have complete myelization of their nerves yet, they have kind of weird movements sometimes. And they'll kind of freak parents out. That's completely normal. Once again, it's not seizure activity. So when do we call status epilepticus? The seizure lasts 30 minutes and you can't relieve it. You'll hear physicians talk about the ictal stage and the post-ictal stage. They want to know how long the ictal stage was and how long the post-ictal stage was. The ictal phase is when the seizure is actually occurring. So what would post-ictal be? After the seizure's over, and they're typically kind of dazed and confused. They're kind of, they're sleepy. They're trying to get up, but they're still kind of lethargic. They're trying to get out of the bed because they don't really know what's going on. So the post-ictal phase can be dangerous as well, because what's the patient at risk for? Falling and injury. They can hurt themselves. So do you leave them in the post-ictal phase? Do you say, oh, the seizure's over, I can leave now? You still want to stay with them until they're what? Awake, alert, and oriented. Because you can't have them fall out of the bed. I'm going to show you. We're going to go over the types of seizures.
This video will teach you about different types of seizures and what to do if your child has a seizure. You will learn about the following: febrile seizures, infantile spasms, focal seizures, drop or atonic seizures, myoclonic seizures, absence seizures, formerly called petit mal, and generalized tonic-clonic seizures, previously known as grand mal. A febrile seizure is a seizure caused by a fever and is not considered to be epilepsy. Up to 5% of otherwise healthy children between the ages of 9 months and up to 6 years will have a seizure caused by a fever. Most febrile seizures occur within the first 24 hours of an illness. Common signs of febrile seizures often begin with a sudden cry, stiffness, followed by jerking of the body, and usually last only a couple of minutes. In this example, notice how both arms of the 1-year-old boy are raised and stiff. His eyes and head are jerky. His whole body is involved. Even though his mother is talking to him, he is unresponsive and unaware of what is going on. Infantile spasms. During infantile spasms, the infant has quick and repetitive movements which can be humorous. This 3-month-old boy is having a cluster of spasms indicated by the extension of his arms. You have to watch closely to notice the seizures, which is why infantile focal seizures are also called partial seizures, because only a portion of the brain is affected when the seizure begins. Common signs of a focal seizure include a blank stare, altered awareness or seemingly being out of sorts, repetitive behavior such as chewing or picking at clothing and mumbling, In this example, the boy's eyes are open, but he is unaware of his surroundings. He is unable to follow simple commands. Focal seizures can last a few minutes. There may be a time of confusion afterwards that can last much longer. Many children are sleepy and may not remember the event. What you should do: speak calmly and remain with your child until the seizure is over or help arrives. Do not try to hold your child during the seizure. Sometimes these seizures may progress to a more serious type of seizure, which we will discuss later. Drop seizures or atonic seizures cause a sudden loss of muscle tone. Here are common signs of atonic seizures. The child stumbles or falls, which can cause injury. The seizure may be mistaken for clumsiness or poor coordination, since the child will usually recover within minutes and be able to stand and walk again. Watch this 3-year-old boy as he stumbles and falls back in this sequence.
These are the kids that usually have to wear a
Here, the child's head drops and he falls backward. He continues to have seizures while sitting in his mother's lap. Notice as his head drops forward, similar to that of catching oneself. Atonic seizures will need to wear headgear for protection from injury. Seizures. Watch the 7-year-old as she does her homework. While writing out her assignments, her hand suddenly stops. She looks up and briefly stares into the distance. Common symptoms of absence seizures include a blank stare that begins and ends abruptly, lasting only a few seconds, rapid blinking and chewing, unawareness of what is going on during the seizure with a quick return to full awareness after the event, felt treatment with seizure medications. A large part of the brain is involved in generalized tonic-clonic seizures. Tonic means stiff and clonic means jerking. Generalized tonic-clonic seizures are the most dramatic of all seizures. They often begin with a sudden cry, a fall, rigidity or stiffness, and muscle jerks. They usually last only a couple of minutes, and the child may be irritable and sleepy for minutes to hours afterwards. This 4-year-old has lost consciousness and is stiff. Notice that his head is turned to the left and his eyes are fixed to the right. The jerking is intense, and his entire body is involved. As the seizure comes to an end, you can see that the jerking is gradually slowed to a stop. Normal breathing returns, and the child goes to sleep. Here is the same 4-year-old we saw having a seizure in his bed. Now happily playing, he has no memory of the seizure he had the night before. Include unresponsiveness, loss of consciousness, possible loss of bladder or bowel control, excessive drooling, shallow breathing, and sleepiness, confusion, or irritability after the seizure. Remember to follow these guidelines with any type of seizure. Do not put anything in the child's mouth. Do not try to hold the child's tongue. It cannot be swallowed. Do not try to give the child food or drink. Do not restrain your child. Keep in mind, your child may be susceptible to a seizure if they have a fever, illness, or infection, they are tired, overheated, or under stress, or are excited, anxious, fearful, or sleepy.
Stress can bring on a seizure. What else can bring on seizures in children? Fever. If they have, if they are known to have epilepsy, what are some other things?
Flashing lights, bright lights,
Video games. Sometimes sound can do it because it kind of startles the child. So who would know what brought on the seizure typically if they have epilepsy? The caregiver, whoever the caregiver is. So what do you need to ask if you see that the child has a diagnosis of epilepsy? What brings on, what starts them, what brings them on?
how long it lasts.
how long do they typically last, and what does the child look like? Tell me the signs and symptoms of the seizure. What are some words that caregivers will use? Do they necessarily say epilepsy or seizure? They might if they know that the child has it, but they may call them spells or fits. So if they're trying to be diagnosed and figure out what's going on, they may use the word when the baby has a spell. So what might you need to use? Tell me what the spells look like. Tell me what happens when the baby has a spell. Does the baby necessarily know what they look like? They may not have any idea what they look like. They may not have any idea what the seizure looks like. So that's why you got to make sure that you're talking to the caregiver. That goes for adults too. I was diagnosed with complex partial seizures, and it took what I was feeling and then what my husband saw in order for the doctor to take us seriously. They kept calling, telling me that I had anxiety and giving me anxiety medicine. Well, the problem with anxiety medicine is that some of them lower the seizure threshold. So what would that be? If I lowered the threshold, what would it be easier for me to have? A seizure. So they were actually giving me medicine that made it worse. But I would have, you know when you go up a hill and it feels like your tummy goes up? That's what my stomach felt like. It felt like my stomach would raise, and I would have images run through my head really, really fast, and it would seem like I was having deja vu is the only thing I could think of to call it. Sometimes I would have a weird taste, sometimes I wouldn't, but they were calling that they were saying I was having an anxiety attack. So it wasn't until my husband saw me doing it, he said that I would stare and that I would start picking my clothes and it looked like I was chewing something. So if I'm ever chewing gum or anything, he's like, "What are you doing with your mouth?" Y'all will see me, I'll picture something in my head and I'm seeing it while I'm talking about it. If I do that, he's like, "What are you staring for? What are you doing that for?" But he had to go with me to the doctor and tell him what I was doing. It's complex because I didn't know always what I was doing. Some of the sensations I could tell him what it felt like, but some of them I didn't. One time I went out, I got a glass out of the cabinet, I went and got a beer from the beer fridge. I came back in, I poured the beer, and then I put the can in the recycling bin, walked in the other room, and I thought, I really want a beer. So I went and got a glass, and I was going to go walk and get the beer, and I realized I had already poured the beer, and I had no recollection of it. One time I was texting Miss Estes, and it was a running text. You had to scroll for a long time to read it all. And that night I thought, I need to tell Amanda something. So I got my phone out and I saw this really long text. Her and me back and forth. It had to have been for a long time because it was a long scroll. But I had already told her what I was thinking about telling her. And it was like normal sentences. It wasn't like crazy stuff that I was putting on there. So you may have to get multiple people. Who else could tell you what the person looked like? A sibling, because it might happen when they're playing. What happens to your respirations when you're running around? They go up. Your respirations go up. So a irregular respiration could cause a seizure sometimes. So if I have an upper respiratory infection and I have an abnormal respiratory pattern, could that lead to I have an infection, I have a fever, I have stress on my body, and I have an abnormal breathing pattern? Could that induce a seizure? What's the physician going to want to know if the child has epilepsy?
What triggers it?
They may want to know what triggers it are. And so if I go into Billy's room and I see Billy have a seizure, the physician's probably going to want to know what was going on when the baby had a seizure. He's going to know what the baby looked like during the seizure and what. How long it lasted. So what do you need to do with you need to time it. You need to be watching the clock. He's going to want to know how long the ictal phase was, and if the baby had a post-ictal, how long that was. I didn't have a post-ictal phase and I didn't have an aura. So what would you tell him about me? Just the ictal phase, what I looked like, what I was doing, and if anything brought it on. Yes.
I think my mama started having hers when she was in school, but hers is sort of like yours, but different. She'll spit. She'll take her hand and she starts spitting, and she'll just put it, wherever she is, she's just taking the spit. And we was at the light company, phone bill company, and she started doing it, and people was laughing. And I was like, she having a seizure, and it doesn't matter where she at. As soon as it's over with, she going to sleep. But we went to Arkansas, and we was at a family reunion, and family reunions are horrible. They fuss. So on our way back, she had 4. And my dad was following us, and finally after the 4th one, I just pulled over because they was just back to back, and Chris just did it. And I think the worst one was when she fell out the bed and she had a grandma. So the seizures changed. And when we got to the hospital, that's what the doctors were asking. How long did it last? What about and my daddy couldn't answer none of the questions, and I wasn't there. So it was like he really didn't have any of the answers.
Right.
All he could say is she was foaming in
You may have to ask more than one person, and you have to keep in mind that the partial seizures can move into the generalized seizures. So she may have started out having her normal partial seizure, and then it progressed into a grand mal seizure. So that's another reason why you don't want to leave the patient. You have the old thing about sticking something in their mouth. You don't want to stick anything in their mouth, but what are you going to do to them? Turn them on their side. And then what do you need to have at the bedside for any of them? Suction. Now, are you going to have to suction me? No, but what if it turned into a grand mal? They have to suction me. People have in their mind these ideas of what seizures are, like when they found out that I had, we did the EEG, and the doctor called me and told me that it was epilepsy. My husband was like, oh my God, are you going to have to wear one of those helmets? And so that's what he had in his mind. And then other people, when I tell them I have epilepsy, they immediately think the grand mal seizure. So you may have to clarify some pre-perceived ideas of what epilepsy is. Yes.
Okay, so when I was in law enforcement, we used to have people fake seizures in the jail all the time to try to get out of the jail. Is there any way to tell whether or not they're faking a seizure? Because some of them can be very convincing.
Yeah.
Stick ammonia and they have HCV on. That would be the only way to tell.
Yeah, that's my own. There's so many different things. What is it? What is it?
If you tell them to stop and they quit, they're probably fake.
I was in the ER and they brought a girl, and like her whole family came in hysterical. She was laying on bed just bopping all over. And Dr. Patterson walked in. He took one look at her. He said, "That's not a real seizure. That's fake. She's fine." Said it in front of everybody, and the girl started slowing down. And he just said it right there in front of everybody. That's
They
fake.
stick ammonia under their nose because they can't. They hate smelling it, so they stop immediately and they hold their breath.
Cassie.
Their face would drop, she'd walk straight down.
Cassie said too that they'll stick ammonia up their nose, and if they're faking, they'll react to it. If they're not, they
I'll
won't.
tell you, some of them can be very convincing.
Yeah,
And they'll
yeah.
fall out and hit their head on
Yeah,
purpose and
yeah,
everything.
yeah.
I mean,
I can't do
So when we're looking at meningitis, where are the meninges? They surround the brain and the spinal cord. So if I have an infection in my meninges, could I eventually get an infection in my brain tissue? Yes. That's not always the case, but it is possible. So I have a itis of my meninges, so I have swelling, inflammation, and infection of my meninges. Once again, it can be viral, it can be bacterial, it can be yeast, it can be a different kind of fungus. So what signs and symptoms? If the lining of my brain and my spinal cord are inflamed and infected, what am I going to feel like and look like? I'm going to have a headache. What's my neck going to be like? It's going to be stiff and it's going to be painful. And when you try to move my head, move my spine, what's going to happen to my headache? It's going to get worse. What's the lights going to do to me? It's going to make everything worse. I'm going to be sensitive to sound, light, and movement. So once again, what do we want to do to the patient's head and neck? Keep it in a neutral position. Are they going to tolerate their head going in any direction? No. So if I have, what is the physician going to do to determine if I do have an infection? Going to draw a lumbar puncture. Am I going to have a fever? Possibly. More than likely I am. So when an infant comes in with a fever, most of the time, if it's a young infant, they are less than 2 months, they'll go ahead and draw a lumbar puncture as a workup to determine whether or not they might have meningitis. I just lost my train of thought. So if I have a bacterial infection, how do they determine if it's bacterial or not? Culture and sensitivity. And what am I going to be put on? IV antibiotics. And what are you going to put on the outside of my door? Isolation precaution. They may go ahead and treat everybody in contact with that patient, so they may treat the entire nurse staff with antibiotics. So you may get prophylactic antibiotics just for being in contact. Can we do anything for the viral? Not. What do we treat with the viral? Signs and symptoms. We monitor for increased intracranial pressure. We do neuro checks. We keep them on isolation precaution. We monitor their fever. We monitor for seizures. But we really are treating the symptoms. If I can pronounce this correctly. Sotonoose is when the baby their spine becomes stiff to the point that it starts to arch. And that is one of the signs that they are monitoring to monitor for meningitis. And that position is due to the irritation of the meninges in the spinal cord. It doesn't have to be to this degree. It could be just a little bit of an arching. And they don't have to have it at all, but that is something that they are monitoring for that tells them the degree of the inflammation and irritation of the meninges in the spinal cord. I forgot my lighting scheme, sorry. If they go to stick the spine, they stick the spine with the needle and they remove it, what could happen to the cerebral spinal fluid? some of it can leak out, and what could that cause? It could cause the because I have a lack of cerebral spinal fluid. It can cause a they call it a spinal headache, and it's due to the decrease in cerebral spinal fluid. So it can cause a headache in a child, even if they don't have meningitis. They can have a headache afterwards. So that was looking at the meninges. So what is this one looking at? It can be an infection, and it can be just swelling of the brain. So it's looking at inflammation or swelling and infection of the brain tissue itself. Encephalitis can lead to meningitis, and meningitis can lead to encephalitis. But one's looking at the meninges, and one is looking at the brain tissue. What is a disease, infection that is becoming more and more common, and especially in the South? That is West Nile. West Nile is an infection that causes encephalitis. My cousin, she had a very high fever. Her parents gave her Tylenol, and they put that she went to sleep, and the next morning they couldn't wake her up, and she had encephalitis, and she from meningitis, and the encephalitis ended up causing permanent brain damage. And she has the mind. She and I are the same age. I'm 40, but she has the mindset of an 8-year-old, which is when the encephalitis happened. So if they had gone to the physician when the fever was high, instead of trying to treat the fever at home, because all they were doing for her was treating her fever, she may not have she may not be where she is now. But that is a case of where meningitis turned into encephalitis, or that is what they believe happened anyway. So what's hydrocephalus? Either there's an overproduction or a malabsorption of the cerebral spinal fluid. It can be primary, so the child can be born with it, and it can also be secondary. If the child has meningitis, if they have spina bifida, they can have secondary hydrocephalus. So their primary disease caused scar tissue to form, and then that led to the malabsorption of the cerebral spinal fluid. Does that make sense? So it can be primary or secondary. This is one of the things that we're looking for when we look at head circumference. So if I have spina bifida or I have had meningitis, what might I be asked to do to my child? Or if my child has had spina bifida or meningitis, what might I be asked to do every day? I might be asked to do a head circumference to monitor to make sure that they are not developing hydrocephalus. So if the problem is the cerebral spinal fluid, what do we have to do to the cerebral spinal fluid? We got to drain it off. So this is a chronic issue, so am I going to walk around with a drain coming out of my head? No, we can't walk around with a drain coming out of our head. So one thing we can do with the cerebral spinal fluid is drain it into the abdomen, where the body will absorb it and get rid of it. So the drain comes, it's in the ventricle, it goes through under the skin, it goes down in the peritoneal cavity. And typically there's a little drain in the back around their neck or around this area that they can control how fast and how slow the cerebral spinal fluid drains into the abdomen. So what if I have a cerebral, a VP drain, ventricular peritoneal drain, and I start developing signs and symptoms of increased intracranial pressure? They're going to have to go in and possibly have that drain adjusted, because what may not be happening? It may not be draining fast enough. It may become occluded. We had a boy in our church that was born with hydrocephalus, and he had a drain. And his drain had to be replaced every few years because it became occluded. Why it becomes occluded, I do not know. But they do become occluded. And there's a couple times where it had to be adjusted due to what? His growth. He knew the signs and symptoms of increased intracranial pressure, so when he got dizzy, when his head started to hurt, he knew that he needed to go and see the physician. Who else needs to know the signs and symptoms of increased intracranial pressure? The caregiver. So you may need to teach the caregiver what kind of check? A neuro check. Is that something you say, now this is what you do, right? What do you do? Return demonstration. The drains can become infected. They can have develop what do we call an infection in our abdomen? They can develop peritonitis, or they can develop encephalitis or meningitis due to the fact that they have a foreign body, sticking in their skull. How do they know? What are my ventricles going to look like if I have hydrocephalus? They're going to be dilated, and I'm going to have an increase in the head circumference. How do they know that there is the position of ventricle? I mean, the position of the drain is appropriate. They're going to go for a CT scan. They're probably not going to do an MRI. MRIs have better pictures, but the CT is faster. So you usually get a CT at the very beginning, and then the patient will go back when they're more what? Stable. So that they can lay there. So the physician is probably going to want an MRI if there's something going on with the patient, neurologically with the patient's head. But you initially are going to get a CT scan. But they like the MRI because it has better pictures. Let me show you this video, and I'll let y'all go.
CSF shunt involves insertion of a valve that regulates and drains the excess cerebral fluid from a patient's brain. The operation normally takes less than an hour, and it is a common procedure done by skilled neurosurgeons. Incisions are made to the head and abdomen. Tubes are then passed through the fatty tissue under the skin. A small hole is made in the skull to allow the ventricular tube to be passed into the lateral ventricle. The peritoneal tube is then placed into the abdomen to allow the fluid to drain. After surgery, the patient will typically spend up to 7 days in hospital to ensure the procedure has been successful. A far more effective solution exists in the form of an adjustable valve. This shunt is identical in every respect to the fixed valve, but critically allows the physician to make small adjustments to the pressure setting by using a remote magnetic programmer, eliminating the need for further invasive surgery and ensuring the best possible improvement for the patient.
Yeah. Okay, we'll start back over on Wednesday. Remember, 12:30 in the library. Be quiet when y'all go in.
Okay, Mark, do you have any lectures?
So we only show up at 12:30.